Hello and welcome. I'm Barkha Dutt, and I'm Barkha Dutt with an acute case of laryngitis today, as you can hear, but couldn't skip the show because there's so much important to talk about, namely Omicron, what we know and what we don't know. That's our big story on the program today, and we have a global perspective coming in a few moments from now. Even as the Indian Prime Minister is chairing a special emergency meet and India is considering new restrictions and new curbs. But does any of this even make sense? What we do know, and it's important to flag the good news first, is that vaccines, while waning in effectiveness, are still providing protection against deaths and serious disease. The hospitalization risk seems to be low as well. At least that's what the reports out of South Africa are suggesting. But can we have a plan for Omicron based on assuming that it will be mild? It is a virus that is galloping and is extremely transmissible. We will be asking our global panel of experts what we know, what we don't know, what we should be doing, and what we should absolutely not be doing. Like I said to our audience and to our panel, please forgive the state of my voice, but I did think that the conversation was too compelling to skip. Let me introduce our guest today. We're joined from the United States of America, from the Mayo Clinic, by Dr. Vincent Rajkumar. Welcome to the program. From London today, we're joined by Dr. Sonia Adesara, who works with the NHS. Welcome, Sonia. Dr. Ambarish Satwik from the Ganga Hospital is with us as well. Welcome, Ambarish. And welcoming back to the Mojo story, Dr. Angelique Coetzee from South Africa, the doctor who first spotted Omicron on a rapid antigen test and then revealed it to the rest of the world. Welcome to the program, ma'am. And let me start with you, Dr. Angelique, if I may. What does the situation in South Africa look like? What's the good news? What's the bad news?
Thank you for asking, and thank you for asking us on this esteemed panel to be part of this esteemed panelist. What we are seeing currently is that our numbers, yes, we still have high numbers as we expected because we have always said this is a fast-spreading virus. However, if you look at our numbers and we look at our ICU cases, our ICU cases are not in line with the same than was seen during the Delta wave. So we've got far less ICU cases. And again, this is now today, 6 weeks ago that I've made the diagnosis of the first patient, the clinical diagnosis. And in 6 weeks, nothing really changed regarding the severity of the disease. I have said before that I have not seen a sick patient that needed to be admitted. Yesterday, or the day before yesterday, I have now seen 104 Omicron patients, and I saw my first patient with pneumonia. And so actually, still mild case for the majority of people, regardless whether the vaccines are protecting you 33% or not against mild disease. It's still a very stable clinical picture that we are seeing out in the communities. In the hospitals, we see an ICU, mostly unvaccinated people. And again, it is pneumonia that they are lying, that they do get. So again, if we look at the people, there are some people that we will hospitalize. It depends on what the situation at home are. But we have seen that for the normal patients in the COVID wards, normal COVID ward patient stay is 2 to 3 days, which is much shorter than with Delta. And in the private sector, we see between 5 to 7 days to full recovery for mild diseases.
Okay, that's the good news. Some people have suggested that it's because South Africa has had widespread exposure to COVID in the past, one, and two, because your population is younger. Do you accept either or both of these, Dr. Angelique, as reasons?
So there's a lot of people give us a lot of reasons. Yes, we have a younger population. Yes, we have a higher HIV and TB burden. Yes, we have a young people that loves to go out and party and socialize. So I would expect that some of them would get severe disease and end up in hospital because most of them are unvaccinated. We know that our people that's vaccinated, the adult population is about 44%. So if we take all of that into account and we look at Europe, especially in the UK, and see how much the amount of people that, or the number of people that's been vaccinated in the UK, it's a high number. So you should also then see, in the end of the day, predominantly mild cases, because that's what we are seeing. So even though we have maybe a younger population, they, as I've said, mostly unvaccinated, while your people are mostly vaccinated. So it sort of add up.
Yeah. Let me take that, in fact, to Dr. Sonia Adesara at the NHS in London. This is a very intriguing situation where South Africa, with a low rate of vaccination, no booster shots, is talking about mild cases. The UK has opted for the third shot or the booster shot. How does the situation look in London, Dr. Sonia?
Yeah, so in the UK, we're about 1 or 2 weeks behind South Africa. So we're at the point now where we're starting to see a real surge in people getting infected. So over the past week, we've seen huge numbers of infections, hundreds of thousands of people being infected every day. So we can see that Omicron is more infectious than previous variants. Now, we differ from South Africa as, yes, we have a more elderly population, and we have a population who have lots of what we call comorbidities, so who have high blood pressure, diabetes, who are overweight, all the things that we know put you at risk for being hospitalized from COVID. The other difference is that, yes, we have a more vaccinated population. So in London, about 2/3 of the population has had at least 2 doses, and then the rest of the UK, it's higher than that. So we're very highly vaccinated. But there is concern that Omicron is able to evade the vaccine immunity. So we are concerned that, particularly if you've had your vaccine, let's say a few months ago, we think that the immunity may be waning from that vaccine. And that's why in the past 2 weeks particularly, we've been giving a booster shot to people to try and just pump up that immunity. And we've been vaccinating huge numbers over the past week. But of course, there's still a significant proportion of the population that remains unvaccinated. And at the moment, the majority of people in our ITUs with COVID or from COVID are people who have been unvaccinated.
Dr. Sonia, how do we understand the role of the third shot? Why is it that South Africa, without the third shot, is reporting pretty much mild cases and not a proportionate spike in hospitalizations? But the UK has opted for the third shot because obviously studies show that the antibodies deplete for all vaccines after a period of time. How do we then understand the South African reporting back on a mild phenomenon when it comes to Omicron?
Yes, you get immunity two ways. One way, and it's from exposure to the virus. One way you get immunity is by a vaccine, which we know that we can get good protection from the vaccines that we have. But the second way that you get immunity is actually catching the virus. So I've just had the virus, and now I know that I've got a good level of antibodies there that will protect me if I'm exposed to it in the future. And I guess another important difference is that South Africa did have a quite significant wave of COVID, over the summer, and I'm sure our doctor from South Africa can tell us about that. So there is some people in the scientific community who say that South Africans had a good level of protection because actually a lot of them were infected in previous waves. Now, of course, that differs between different countries. Some countries had widespread infection. Other countries had more measures in place to stop people getting infected, and that means there's less natural immunity there in the population. So that's why countries differ slightly, and that's why in the UK we pushed to have this booster vaccine to push up people's immunity. And also UK, a bit like Israel, we were vaccinating people very early on. So there's many people, I had my first and second dose of the vaccine at very, very early on, so over a year ago. So whereas other countries, people are vaccinating later, so they may still have better protection from that second dose of the vaccine.
Dr. Vincent, the anti-vaxxers will have a field day with this argument about natural immunity. The argument is also being made that countries like India and South Africa are having a different experience because seroservice suggests a widespread prior exposure to the virus, at least in a different form, to Delta, certainly. Surely that can't be strategy. Let everybody get infected, that's a good thing. Unless we're suggesting that the virus is actually losing steam. Do we know that?
Thanks for having me, Barkha. I'm unfortunately, we don't know that. I mean, we don't know whether Omicron just is milder in terms of deaths or also all of the other things that it can do. And then we also don't know what the long-term implications would be. So I don't think getting infections is a good idea. But people should know that, as was pointed out, whether due to previous infection or vaccine-induced immunity, people are still getting COVID in the UK and South Africa. And that means that there's a finite duration of protection from getting infection. What we are hoping is that whatever infection happens is milder. And you do see that in South Africa. You also see that in the UK right now and in Spain, where cases are skyrocketing, but deaths are not increasing as much. That's some hope, but whether that's truly from a milder variant, partly, or really the amount of people who have already been exposed to the virus or the antigen through vaccine and have some immunity, and that's helping them, we don't know. So why it matters to India is India had the first and biggest Delta wave, which probably gave a huge number of people immunity. It has given 40% of its population one dose of the vaccine. So that's the good thing. The hard thing is that hardly anyone's had a booster. Only 20% have even had a second dose. So you're really banking on the primary infection with Delta protecting from a subsequent wave. That's a risk because we know that risk happened last year.
Yeah. In fact, there's a lot of deja vu compared to last year. We're in election season in India again. There are calls to call off mass congregations. We are restricting Christmas and New Year, but not talking about restricting election rallies. So there's deja vu in all kinds of ways, except the one big difference. We have vaccines. We did not have vaccines a year ago. Dr. Ambarish, Satwik, I have to ask you this. The Oxford University is today saying that AstraZeneca, which we know as Covishield in India, also offers significant protection with a third shot. India has not taken any decision on a booster dose yet. Do we need boosters as of yesterday, or is the jury still out on that?
Yes, thank you. So when you talk about boosters, you also have to mention which vaccines were administered to prime the individual. All right. Now, the evidence we have from Southampton seems to suggest that if someone's primed with the Oxford vaccine twice, then a third shot of the Oxford vaccine is not going to do too much. And therefore, perhaps an mRNA booster is the right booster for these individuals. There's another vaccine, which is Novavax or Covovax, which is going to be manufactured by Serum Institute, which has shown reasonably good results on when the booster is applied as regards neutralizing assays. The trouble is that 90% of Indians who have received the vaccine have received 2 shots of Covishield, which is the Oxford AstraZeneca vaccine. So the proposition is that the Oxford AstraZeneca vaccine is an adenoviral vector vaccine, which means that you take the chimpanzee cold virus and through genetic engineering introduce the genetic material of SARS-CoV-2 and use that as a vaccine. So when you administer a booster shot, it's possible that antibodies formed against the viral vector, the adenoviral vector, render the booster ineffective. Therefore, we have to possibly consider Covaxin, which is an inactivated viral vaccine, or perhaps Covovax or Novavax. Now, the Southampton study seems to suggest that the inactivated viral vaccine that was used there wasn't particularly effective as a booster. Also, we have no data on Covaxin being used as a booster. The Southampton study, they started recruiting in July 2021, Right now, Professor Kang in CMC Vellore is doing a randomized control trial on boosters. And the randomized control trials provide level 1 evidence, excellent evidence, but they take forever. So we probably have the results after we're done with Omicron. But
Yeah.
just to kind of add to what has been said, I was looking at data from South Africa today, as I have been every day. And this is very encouraging data because it's over the peak now. And still, the number of people in ICUs in all of South Africa is about 613 today. The number of hospitals reporting to this data are about 611. That means just more or less one patient with COVID per ICU, roughly, if you were to average it out. There are just about roughly 235 patients on ventilators, on mechanical ventilators, in all of South Africa. South Africa has a population of less than 60 million. Delhi has a population of less than 20 million. And Delhi, in our last sero survey, showed 95% seropositivity. Most of that acquired from previous natural infections, because what we saw truly, the death and devastation in our Delta wave, we saw a complete kind of Malthusian crisis. I mean, viral infections were growing exponentially, resources, hospital beds couldn't even be added arithmetically. So we've seen the worst. And therefore, my sense is that it's possibly going to play out quite like it's playing out in South Africa, at least in Delhi. But, as we're all creatures of this tragic age, I wouldn't want to fate by saying this.
Yeah, fair enough. Angelique, would you like to pick up on the South African experience and tell us a little bit about what symptoms? A lot of people, we get a lot of questions. When should I test? If I have a sore throat, I mean, I have one right now. If I have a sore throat, should I be rushing for an RT-PCR? What are the most common symptoms you are finding in the patients who are coming to you? And how is it different from Delta?
Thank you again. That's extremely important. And we always forget that there's actually a patient out there that doesn't know what is happening to him or her. So the easiest way for me to describe the Omicron, it's more a muscular type of disease, meaning you will, let me explain it different. So most of the patients, the majority of patients will come in today and say, Doctor, when I went to bed last night, I was healthy, fine, nothing was wrong with me. During the night, I felt hot and sweaty, and with sometimes cold. And when I woke up this morning, I had this terrible headache, and my chest is sore, or my back is sore, or my body is sore, and I've got this type of a fatigue. Maybe a little bit of a scratch throat, doctor, but it's more this headache and this sore body that I don't understand, with this bit of a fever during the night, because I interpret it as a fever. That's Omicron. Omicron doesn't give you a patient coming in says, Doctor, my throat are extremely sore, I'm sneezing, my nose is blocked, I don't have any smell, I can't taste. That's not Omicron. So Omicron is more musculoskeletal type of presentation when they come in the first time. So this is extremely important, because you can easily miss it because you're waiting for the blocked nose and the running throat, the sore throat and the terrible cough. It's not there. It comes later if it comes. Okay, so when do I test? What we have seen, this is experience. If you wake up this morning and you come to me within 3 or 4 hours and you want me to test, I would rather ask you to come back the next day and go and self-isolate for the first few hours. Because we have seen if you immediately test them, you can get a false negative PCR. However, if I test them around about 18 hours later, up until 5 days, it's a beautiful positive test, and you can accept that test. If the patient come, however, in and say, Doctor, 1 week ago, I started with this body ache and pain, and now I'm just fatigued and a bit of a scratchy throat. My headache is not so bad anymore, but I'm still not feeling well. Then you do a PCR. If you do that PCR, or if you then do the rapid test, you will find a negative rapid test. So you do the PCR.
Right.
And that's how you distinguish between that. And then what we have seen, what is different than with Delta, we have seen that if you immediately start them on a low dose of cortisone, ASAP, that's actually all you need with a bit of an anti-inflammatory. Ibuprofen works like a bomb. That's all you need. You don't need other medication, not at primary healthcare level with these symptoms.
That is so useful to know because one of the things we did, at least in India, is over medicate. We know that now because there were no therapeutic interventions that were available. Pfizer, of course, has approval for a new pill, so there's a lot happening on the medical front. But Vincent, the Americans are struggling with enough testing kits. What's going on with that?
I'm not sure. I think the FDA was very slow in approving rapid tests. They're treating it like a therapeutic intervention. So the rigor with which they are approving, and then the manufacturing and the number of kits that we need for such a large country is just not there. And they've just been announcing that they're going to give away kits. And yesterday there was a video that one of the reporters, Dan Diamond, had posted on Twitter with lines going 3 times around the place where they're distributing kits, people waiting for hours to get kits. So I just hope that we get kits sooner so that people can test them when they get these kind of symptoms to know when to isolate. But I think the good advice that Dr. Coetzee gave is that if you do feel like you may have it, just isolate, self-isolate. And that message also has to be sent out so people are aware when to take precautions.
What worries you? You've heard the good news about the low hospitalization. What, if anything, still worries you, Dr. Vincent?
So what is worrying is that for the last 2 years, people have postponed almost all of their other care for all the conditions that people usually get, from cancer to heart disease. And hospitals are already very, very full. And the US is just slowly recovering from the Delta wave, and there's still a lot of patients in the hospital. And then Omicron adds to that, and this is a very large country with a lot of comorbidities, elderly people. And even if a small number of people get hospitalized due to Omicron, that will cause problems. And we are not as well vaccinated as we would like to be. We are only 60% fully vaccinated, even though we have all the vaccines that you can have in the world. So those are the things that worry me.
Right. Let me take this to Dr. Sonia. Dr. Sonia, the big debate is whether a virus as transmissible as Omicron can in fact be stopped by the kind of containment measures that were used in 2020. In fact, the argument would be that you can't go back to the future. It would be anti-science to try and do that today. There's been a huge debate, I know, in your country over Christmas, including the Prime Minister himself being dragged into that debate over whether he attended a Christmas party or not. What would you feel as a doctor in terms of restrictions? Do they even work for something as galloping and transmissible as Omicron?
Yeah, so we know if we bring in restrictions to reduce people interacting with other people, then of course it will reduce the spread of the infection. That they do work to an extent. The big debate that we're having currently is, yes, we are looking at South Africa, and the positive signs are that it may be less severe, less hospitalizations, and we do have good protection from the vaccine. So that's the positives. The negatives is even if it is less severe, if we are seeing huge numbers of people infected, and even if it's a smaller proportion that will need hospitalization, that still can be a very significant number if you're seeing large amounts of people being infected in a short amount of time, which is what's happened in the UK. And then the other concern is that in the UK right now it's winter. So winter is always the most difficult time in our health service. And even prior to COVID, in the past few years, we were having a very difficult situation in the winter where many hospitals have been running close to full capacity, some hospitals running out of hospital beds. And that's what happened last winter as well. We ran out of hospital beds in many hospitals, particularly in London, and we were running out of ITU machines and running out of CPAP machines. So there's a concern in the UK that if because it's winter, it's Christmas, people are socializing more, mixing more. If we continue to see these increased infections, even if it's less severe, even if it's a very minority of people who are needing to be hospitalized, if the numbers are so big and it's such a short amount of time, there's a concern that the health service won't be able to cope and then won't be able to give everyone the treatment that's needed. And also, as your other guest just mentioned, there is a concern, like we know that because of COVID and the pandemic and all the measures, we know that other people with other conditions, whether that's cancer, whether that's so many other conditions, have had that neglected. And we know that many people have had their waiting for operations now, sometimes for a year, 2 years, and they're getting more sick and more disabled because of it. And again, we're in the situation where some hospitals are having to cancel their operations to try and free up space in the hospitals. So we are potentially making it worse for people with other conditions as well. So it's a difficult situation. And yes, Christmas is really important. People like to mix, but it's trying to do so in a way that doesn't mean that January time we are in a very difficult situation.
Yeah. In fact, in India, the big knock has been to the Indian fight against tuberculosis. We were aiming to end TB by 2025, and that is just not going to happen now because the health system has just been entirely preoccupied with COVID. Ambarish, Delhi is considering restrictions for Christmas and New Year's while election rallies go on.
It beggars the imagination, but of course, I think I couldn't stress again on the need to kind of stagger exposure, because someone said if you get a year's worth of rain in a month, obviously you're going to get flooding. But let me say that there are three takeaways for me, so far as regards the pandemic. The first is that zero COVID is not a possibility. You can't suppress this, you can't eliminate this to a point that it doesn't exist, at least currently. You can't do that. Secondly, you cannot, it's almost certain to everyone in the field that you cannot vaccinate yourself out of the pandemic, because vaccines as they're currently available are not 100% effective. You cannot have ever 100% uptake of these vaccines, and you have waning immunity, so you will be playing catch up. To answer your question about why it seems to most people that natural infections are offering a better protection or better in the sense that it's more comprehensive and can summit, is because it also gives you mucosal protection. It gives you mucosal IgA antibodies, which the vaccines are not able to provide. This is not an anti-vaccine message. In fact, I couldn't edify vaccines more. They're tremendous as regards personal protection, but the message has to be clear that double vaccinated is not equal to not infectious. Because if that's the message you're giving out, then that could be a source of great problem. Also, I'd like to play interlocutor here for you and ask Dr. Sonia and Dr. Angelique, because some of the data that's coming in from South Africa and the UK needs to be more granular, because apparently I've heard that about 40% of the people who are currently hospitalized in the UK with Omicron have been incidentally diagnosed with Omicron because they were admitted for something else, and it's mandatory to get a pre-admission test. Similarly, in fact, someone mentioned that almost 50 to 60% of the hospital admissions in South Africa were incidentally diagnosed as Omicron, and because they've been categorized as hospitalizations. Actually, if it's true, that's again a source of great relief for all of us.
Yeah.
So,
so Angelique, do you want to take that first?
Yes, it is. It's true that the majority of the people that has been in the hospital are patients incidentally tested positive, and that was one of the. There was a huge hype about the children that's been admitted to hospital, and there's a higher increase of children with Omicron in hospital, which was not true. It was children that was admitted for upper respiratory tract infections, not due to Omicron, tested positive in the hospital, and unfortunately, as part of the stats, they would then count as COVID positive. And we saw exactly the same in the adults or other people when they are admitted. So that will always fall under COVID patients because it's part of stats. Unfortunately, it doesn't distinguish between it's actually secondary, primary. There was another reason for them to be admitted.
But it's good. It's good news because it isn't Omicron that got them into the hospital. So it's good news, right?
Then it's not the Omicron that got them in the hospital. It's something else that got them in the hospital, and then they got they then tested positive. But it means this might be a problem because, as some of the previous speakers said, if these people are not controlled with their diabetes, hypertension, whatever, and they don't know they've got this disease, and they get a side effect, a secondary infection or progress, it's a problem.
Yeah, Sonia?
Agree. So everyone gets a test when they get admitted to hospital. So it is true that some people would be, let's say, admitted because I think they're having a heart attack and then test positive. We also know that the infection spreads within health and care settings, so whether that's care homes or in hospitals. So we know that people are in hospital and then they become infected, whether that's from other patients or from staff. We are at the moment still in the hospitals. The majority of people who are being admitted because of COVID, it's still Delta rather than Omicron, and that's because of the lag time between people getting infected and needing to be hospitalized. But also, if let's say you're being admitted because you need surgery for cancer, and then you catch the virus whilst you're in hospital, it's not necessarily a good thing, as the other speaker said, because you are, just by the fact that you're in hospital normally means that you're more vulnerable, whether that's because you've got health conditions. So you are more at risk of needing more severe treatment and more at risk of needing ventilation as well.
Well, in the end, I think there's agreement that so far Omicron has seemed mild in terms of hospitalization and severe disease. But Dr. Vincent, there's some concern about long COVID. I was looking at some studies that are looking at COVID not as respiratory, but as a neurological disorder. There is still not full comprehension of brain fog, which is how most people describe long COVID. Any thoughts on that?
Well, certainly, as I mentioned before, certainly because of either prior infection, prior vaccination, or that intrinsically it's a milder variant, it does appear milder. But that in terms of deaths, maybe in terms of hospitalizations. But whether that's true for other complications, we don't know. And then we just have to be careful. I do want to point out we were in thinking almost the same last year around this time, that India has gone 2 months without anything. We went another 3 months without anything, and then the Delta wave hit. And that's why I think one of my takeaways would be you have a population of elderly people, because it's a vast country, even though it's a small percentage of the population, it's still a huge number. And most of them have had only one dose, some have had two. But I think you really need to look at a booster shot for people who are elderly and immunocompromised in India now. We know that AstraZeneca, the Lancet study that just came out 2 days ago, the protection from AstraZeneca vaccine against severe disease is about 85% 2-3 weeks after the second dose. But it dropped to 40 to 60% in the studies from Brazil and Scotland. And since only 20% of Indians have even had 2 doses, you really need to ramp up the double vaccination in parallel with the
40% of the country and 60% of the adult population is the latest figure. But Ambarish, last word to you. Even if India decided to boost, what would it boost with? If mixed vaccines are the way to go, Covaxin, the volume has always been a problem. If Delta remains the primary variant for India, then the argument could be to boost with Covishield.
So my sense is that we're kind of done with Delta. We saw roughly under 50 cases a day in Delhi for 6 months running after the death and devastation from April and May, because practically Delta ran out of people to infect. We're now 65% double vaccinated in Delhi, and roughly about 95, 97% seropositivity. But that imperishable quotation from Ed Yong comes to mind. Ed Yong is the science journalist who writes for The Atlantic. He says, immunology is where intuition goes to die. So no one knows whether Omicron will produce effects of long COVID. No one knows if Omicron will be mild in India. No one knows. The late Chinese Premier Zhou Enlai was once asked about the effect of the French Revolution, and he said, it's still early to tell. So it's still too early to tell.
Well, on that somber note, yet grasping at some of the good news that Angelique has got us from South Africa and Sonia too, in terms of hospitalizations and severe disease, we still need to grab the little bits of good news that we can with both hands. It's been that kind of year. I'm going to say thank you. This was a great panel. To have perspectives from 4 countries, I think that's rare. Learned a lot. Thank you for the service that all of you do at the front lines. Dr. Vincent, Dr. Angelique, Dr. Sonia, Dr. Ambarish, and to our audience, thank you. Sorry for this voice. Hopefully I'll be back in full force soon. Thank you for watching. Goodbye.
It's great to see you here. Thank you for watching our work. If you haven't subscribed yet, don't forget to click the bell icon and subscribe to Mojo Story and support independent, robust journalism.